Hi, I'm Dr. Laux, and I'm going to share a few thoughts about repeat radiation treatment after a person has had a mastectomy, and particularly where radiation was previously used for the intact breast. And thanks for joining me, and I look forward to meeting with you if you're watching this in anticipation of a consultation with me. So again, our situation is a prior history of breast cancer where the first surgery was a lumpectomy and included lymph node sampling where the lymph nodes were all clear and where unfortunately cancer has been found again in the breast, and that's now been treated with a mastectomy. So the key question is, what is the risk of a future recurrence of breast cancer after the mastectomy, and can we reduce it, and if so, how? And things we need to think about are, uh, what was the size of the cancer that was removed at the mastectomy? Was it invading the skin? Was it invading the chest wall? Was it high grade or not? Was it tracking in little microvessels around the tumor? And did it involve lymph nodes if they were taken at the time of the mastectomy? And each of those factors is important. And the risk of having yet another recurrence after that mastectomy is at least 20% if we have features like high grade or involvement of nodes and microvessels or skin invasion. So that makes us think about, can we roll up our sleeves and do something to reduce that risk? And if 20% is if you will, a floor of significant risk, it can rise to even 40 or 50%, depending on the nature of the findings. So in general, post-mastectomy radiation has a good track record of lowering risk by at least 50%, and in old series, perhaps more if the risk was 25% without the treatment. The risk with the treatment was not zero, but maybe 5% or so. So over the years, radiation was generally used when there were several high-risk features present at mastectomy, whether or not there had been a previous problem with the breast. So how do we factor in the prior radiation? Well, it becomes a matter of thinking about the benefits and the risks. So let's look at those. So we first look at, what about that prior radiation? Exactly where was it? Was it just the breast, or did it involve the breast and the lymph nodes? Was it a short time ago, or has it in fact been several years? Now, when we look at what was treated, and here's just a couple of cross sections through the chest and breast area where radiation beams skim from one side to the other, or they form an radiation is delivered in the form of an arc that follows the shape of the breast or chest wall. You can see that the skin, the soft tissue, and the rib cage and a small rim of lung tissue is always included in those treatments. And when the regional nodes are treated, there's a fair amount of soft tissue, of course, in the area under the arm and extending along the area of the collarbone just to the inner aspect at the neck. So those are tissues that the breast would have been exposed to radiation, and depending on the prescription, the regional nodes may have been. So we look at that in an individual case. Then we ask about what was the treatment experience for the patient before. Did the treatment cause much bother? Did it cause the formation of a lot of fibrous tissue after the treatment? Or was it what we'd call well tolerated with minimal normal tissue side effects? And when we look at the recent past, did the prior radiation interfere with healing after the recent mastectomy? If it didn't, well, that's all the better. We look at the question of the lymph nodes. If the nodes weren't previously treated and the recurrence has involved the nodes, general principle is that we should treat that nodal area. And if it wasn't treated before, then we typically don't have to have any meaningful concerns about that because that's tissue that hasn't been exposed to prior radiation. That would be the lymph nodes under the arm and extending along the collarbone towards the lowest part of the neck. Now, as we mentioned, all of the chest wall would have previously received a meaningful amount of radiation. That would have an imprint on the normal tissues. And over the past 10 to 15 years, some guidelines have been developed about repeat radiation. It used to be that typically just wasn't done unless you were really pushed hard into a corner because of the concern about normal tissues. Now, various institutions have gathered series of cases that have been retreated. No one has a really big series of cases that are all the same, but rather small numbers with a variety of cases. Some where the mastectomy cleared all the visible cancer, some where there was cancer left on the chest wall, some that had chemotherapy or hormone treatment, some whose radiation was given with protons or with a type of heat application, the so-called hyperthermia. So a really wide range of approaches, and so obviously hard to draw really firm and absolute conclusions. But what has been learned is that, yes, skin effects during and after a retreatment course are going to be more than on the first course, but in general would be tolerable. But perhaps 1 in 5 might develop uh, enough skin problems that they need special care for that. When we look at the later effects, which is the ones that for which is the biggest concern, depending on these various series, up to 20% of people can have meaningful problems with scar tissue formation, or because of the delicacy of the tissues on the chest wall, the potential to develop some ulcers that require special treatment, or some breakdown of the soft tissue that requires continuing care. So that's a significant issue. Obviously, the majority of people don't get it, but it is a risk that we need to put right on the table. When we look at other tissues, there's that little rim of lung tissue beneath the treated chest wall will form some fibrosis. Importantly, because it's not a large area, its impact might not be noticeable, and it would depend on the person's baseline lung function. If the lung function was good, it shouldn't be a problem. If the lung function is marginal, then that could be significant. When we look at the rib cage, it does receive the second prescription dose, and that would entail a greater risk of rib fracture in later years, which may or may not cause symptoms. And the various series have not really commented much on that, so it's not possible to state a specific percentage risk for that, but it is a risk. And the heart, of course, on the left side is a potential area of radiation exposure, and various methods can be used to absolutely minimize the heart coverage. And over time, some general guidelines have been developed about what is the maximum, but you can't avoid it completely. Again, if a person has major heart issues or risk factors at the outset, it's probably more significant than if they don't. So if we stand back and look at it, weighing those risks and benefits, uh, if there is a meaningful number of risk factors for recurrence after surgery alone, say it could be in the 20, 30, even 50% range, radiation definitely adds to what surgery and drug treatment can do to control the cancer. So for high risk cancer patients, the benefits of radiation are believed to outweigh those additional normal tissue risks that I discussed. So current guidelines say retreatment of carefully selected patients is a reasonable and indeed an appropriate thing to do to avoid that yet another recurrence that can be hard to manage. So the conclusion is that repeat radiation is definitely on the table, and it appears to be of greatest benefit after a mastectomy for recurrent cancer and where the patients had previous radiation if the margins are clear, and it's especially if the cancer is high grade and has spread to the lymph nodes. And thanks very much for your attention, and I look forward to discussing these points with you when we meet, if you have an appointment with me. Thanks again.